All right, let's dive into a really high-yield topic in trauma, one that every medical student absolutely needs to get a handle on: femoral shaft fractures. Now, these aren't just your run-of-the-mill broken bones. We're talking about major traumatic events that carry some serious life-threatening potential. So let's get right into it.
So let's kick things off with a classic scenario. Imagine you're in the emergency department and a patient gets wheeled in after a nasty fall on the ski slopes. Their thigh is obviously deformed, it's swollen, and they are in absolute agony. You're thinking, okay, this looks like a femoral shaft fracture. What's the very first thing that should be screaming in your head? What's the one complication that could kill this patient, right here, right now? Just keep that question in the back of your mind as we go.
Okay, so to get to the bottom of that question, we first really need to understand the entire clinical picture. Let's break down how these patients typically present and the kind of forces that are involved. Because recognizing just how severe this injury is, well, it all starts right here.
The signs here are usually pretty hard to miss. This is not a subtle diagnosis at all. The patient's going to be in severe pain with a really obvious deformity of the thigh. It just won't look right. If you were to carefully examine it, you might even find pathological movement where there should be solid bone. And because of the incredible pull from those powerful thigh muscles, the leg will often look shorter than the other one. These are the classic hard signs of a major fracture.
And that brings us to how this even happens. Yeah, these don't happen from just a simple trip and fall. We are talking about some serious, high-energy trauma. Think about the direct impact from a car crash, or those powerful twisting forces you can get in a skiing accident, just like our patient. The takeaway here is crucial. Always associate this type of fracture with a massive amount of energy being blasted through the patient's body.
Okay, so let's circle back to our patient and our big question. They're on the gurney, thigh is a mess. What is that immediate life-threatening risk? The answer? It's all about the bleeding, hemorrhage. This is the #1 priority, because in trauma, we always live by the rule, treat first what kills first.
So why is the bleeding so bad here? Well, it's not just a little bit of oozing from the bone. See, the femur is wrapped in this huge envelope of muscle that's just packed with blood vessels. When that massive bone shatters, those sharp, jagged bone fragments act like little knives, and they can easily shred through major vessels and all that surrounding tissue. The real threat isn't the broken bone itself. It's the vascular disaster that's happening deep inside the thigh.
And just how much are we talking about? This is the part that should really get your attention. A patient can lose up to 2 liters of blood into a single thigh. Just think about that. That's not just a number to memorize for an exam. That's a patient who is rapidly spiraling into severe hemorrhagic shock. This right here is why a femoral shaft fracture is a true trauma emergency.
Okay, so we've spotted the patient. We know the immediate danger is hemorrhage. What's next? Well, we've got to confirm what we're seeing and lock in the definitive game plan for treatment.
Look, even though you can be pretty darn sure just by looking at the patient, you still need to get that radiographic confirmation. A standard X-ray, making sure you get at least 2 views perpendicular to each other, is absolutely essential. And just like we saw on the physical exam, a really common finding you'll see on that X-ray is shortening, as those big muscles just pull and contract the limb along that fracture line.
So how do we fix this? Well, the path forward is actually super clear. The standard of care is surgical osteosynthesis, basically surgically fixing the bone. For adults, conservative treatment like putting them in a cast, that's pretty much off the table. The specific gold standard technique that you need to know is the femoral intramedullary nail.
So let's walk through the whole management pathway, step by step. First things first, you stabilize the patient, following your ATLS protocols. That means addressing that massive potential blood loss immediately. Step 2, once they're stable enough, you get your X-rays to confirm everything. And finally, step 3, you move on to the definitive fix, surgery with an intramedullary nail. It's a really logical flow from managing the life threat to fixing the underlying problem.
Okay, that was a lot, I know. So let's boil it all down to the absolute must-know, high-yield takeaways that you should carry with you from this.
All right, let's hammer these key points home. If you remember nothing else, remember this. 1, anytime you have high-energy trauma to the leg, you have to be suspicious of this fracture. 2, the #1 thing that can kill your patient is massive hemorrhage. We're talking up to 2 liters. 3, diagnosis is confirmed with an X-ray, and you'll probably see shortening. And finally, 4, the undisputed gold standard for treatment is surgery with a femoral intramedullary nail.
And to wrap things up, I want to leave you with a little challenge, a what-if scenario. We've said that intramedullary nailing is the standard. But no rule in medicine is ever 100% absolute. So, what kind of situation, maybe something involving severe contamination or a patient who's just too unstable,
might force a surgeon to say, nope, we can't use a nail here. And what would they do instead? Thinking through those kinds of exceptions, that's what really takes your knowledge to the next level.